Hi everyone, my name is Saeed Hashem. I am a fellow of geriatric psychiatry at the Center of Excellence for Alzheimer's Disease in Downstate, and I'm also a clinical assistant instructor in the School of Medicine. I'm also part of the Bridge team for the Brooklyn Initiative to develop geriatric education, and I have you here today to talk about a very important topic for older adults, which is sleep and its related disorders. This presentation is supported by the HRSA grant with 0% financed through non-governmental sources. The contents are those of the author and do not necessarily represent the official views of the HRSA, the HHS, or the US government. I have no conflicts of interest to declare, and I will discuss some off-label discussions, and I will discuss some off-label pharmaceutical therapeutics for insomnia and restless leg syndrome later in this module. So I'm talking about sleep today because it affects 3 of the 4 M's in the framework for the age-friendly health systems. It affects what matters, it affects medication, and it affects mentation. So please take a moment as a healthcare provider and consider how would you discuss the importance of sleep for your patients. Take another moment and think, how do you prioritize your own sleep? So let's talk a little bit about the epidemiology of sleep in general in the United States. So according to the American Academy of Sleep Medicine, adults between 7 and 64 need somewhere between 7 to 9 hours of sleep per night. Older adults require basically the same, maybe the allocation of the sleep hours might be different between nighttime sleep and daytime naps. Only 10% of Americans prioritize their sleep, which is unfortunate, and a third of them report sleeping than 7 hours per night, according to the most recent surveys. Almost 50% of Americans report feeling sleepy during the day, and that goes on from 3 to 7 days per week. Major cities in the north report higher sleep insufficiency compared to the southern ones. And sleep is particularly worse in women, single parents, and workers in production-focused industries. Veterans and military personnel report very high rates of sleep insufficiency. There are also ethnic differences in America when it comes to sleep insufficiency, with Native Americans reporting much higher prevalence of insufficient sleep compared to Latinos and whites. Other vulnerable groups that can have insufficient sleep include older adults, the topic of today's module. 50% of them have inadequate sleep, with almost a third of them using sleeping pills. Psychiatric illness makes you at risk of having poor sleep, including mood disorders, dementia, and substance use disorders. Medical illnesses can impair your sleep, including acid reflux, pulmonary disease, metabolic syndrome, Parkinson's disease, and stroke. Urinary incontinence is another problem because it makes your sleep interrupted. Let's talk about the physiology of sleep. How does sleep happen? How it's regulated? What are the functions of sleep? So let's talk about normal sleep architecture. Normal sleep in most individuals is composed of cycles. Each cycle is somewhere between 70 and 120 minutes, 4 to 6 cycles per night. Each cycle is composed of different stages, basically categorized into rapid eye movement sleep and non-rapid eye movement sleep. So the first stage of sleep is called the N1. N is short for non-REM sleep. It has light sleep, very close to wakefulness, your muscle tone is still preserved, the brain starts to slow down, and the EEG shows typically theta waves. Then you go to the deeper sleep, N2. With muscle tone still preserved, your brain and body slows down even more, and the EEG show characteristic sleep spindles and K complexes. And then N3, which is the third stage, also called slow wave sleep, where the brain and the body slow down even more, and the EEG is predominantly delta waves. And then comes the REM sleep, which is characterized by low muscle tone, with the autonomic nervous system and the cortex very active. The EEG shows a lot of desynchronized theta waves and sawtooth waves. So let me explain how sleep progresses through the night. This is a sample of one sleep cycle This graph is called the hypnogram. It shows that we start with wakefulness, we move to stage of N1, and then we go to N2, and then our sleep oscillates between N2 and N3 for a while, and then we go from N2 to the REM sleep, and that concludes one sleep cycle, after which we either wake up or we go for another sleep cycle. So we transition from REM sleep back to N1, and the cycle is repeated. Each cycle, as you can see, is somewhere between 75 minutes to 90 minutes, and in some individuals it can go up to 120 minutes. So in cycle normally proceeds in this following order, from N1 to N2 to N3, back to N2, and then REM sleep. Please notice that we spend a lot of time in our sleep normally between N2 and N3. So let's talk a little bit about the neurotransmission involved, the differences between the non-REM and the REM sleep. So in non-REM sleep we have low acetylcholine activity, while in REM sleep we have high acetylcholine activity. In non-REM we have high release of monoamines, especially serotonin, while in REM sleep monoamines are silenced. In non-REM sleep there is a declining cerebral blood flow as you go deeper in sleep, while in REM sleep higher blood flow is characteristic, especially in the hippocampus and the temporo-occipital areas. And later in this module, you will understand why these differences are important to highlight.